some stability. How stable does it make it? Does the tape loose? Oh yeah, big time. Yeah, it gets loose the more you do. So these are a little bit more rigid. This is a really standard a lace-up brace. We will practice with this in the afternoon. This is an excellent brace, and you can adapt it accordingly. But this is wonderful. A lot of athletic departments and so forth in high schools, sports teams don't have budgets for tape and athletic trainers and so forth. We can all show people how to wear this and wear it correctly, so we will work on that. This brace is actually up at our Wadley campus right now with a cheerleader. This is the best ankle brace I've ever seen. It's called the Malleolock. It's rigid plastic. It's very comfortable. It's really, really simple, but the German design of it really just, it will not allow you to invert your ankle, okay? Matter of fact, you will see a lot of Division I athletes and so forth that don't want to wear tape will wear this, okay? This is kind of an air cast stirrup. Anybody worn one of these? Okay, these are pretty standard as well. You'll see these a lot of times. They have a very cushiony, with like a honeycomb deal on the inside. You put your foot in. Here comes the uprights on the outside. You wrap it around, and again, it's not going to allow much inversion in the eversion. It will allow for dorsiflexion and plantar flexion. So we'll practice using these and applying these this afternoon. But pretty standard stuff there. Weight bearing as tolerated. You've got somebody with an ankle sprain. The tendency for them is going to be walk on their toe like this, right? And now it may have crutches or whatever. What's wrong with that? What muscle is contracting when I do this? Gastroc soleus, okay? So when they do that, and they do that over and over and over and over, they're going to get Achilles tendonitis, they're going to get tightness up in here in the heel cords, they're not going to be able to dorsiflex. So one thing you want to make sure that you're doing is you emphasize to them, even if they've got to have crutches or a cane or whatever, is they get onto their heel, okay? They have to get onto their heel. It may be a flat foot gait. They may not be able to really go like this, but at least get to that heel and be flat, okay? We don't need Achilles tendonitis on top of an ankle sprain. I've seen it a million times. General range of motion. What's one way to do that? Still can't do it. How can you do general range of motion? Yeah, you can do circles, you can draw the alphabet, you can draw numbers, whatever. Get it moving, okay? And tell them, if it really is painful to do one certain part of the letter or whatever, avoid that for the time being. But we need to get them moving. That includes doing flexion, extension of the toes, inversion, eversion, dorsiflexion, plantar flexion, all this kind of stuff. If it's a grade 2, grade 3, you're going to want to avoid the plantar flexion inversion that got them there in the first place. That's just common sense, right? If we've got ligaments on the outside of the ankle that are trying to heal, we don't want to overstretch them, okay? So make sure you tell them that. If it hurts, don't do it. Except for that thing about the walking. You got to get them onto their heel. Isometrics can kind of keep everything in shape or prevent the atrophy from occurring. Again, I try to get them out of the isometrics as quickly as I can. But this is phase 1, okay? How long will this be? It's a great question. It totally depends. It begins when? Phase 2 will begin when Range of motion and isometrics are pain-free. Edema is controlled. It will not go away. It will not go away in phase 2, okay? And we can weight bear without an assisted device. That's when we can start the second phase. At that point, we can continue with the RICE, the splinting, the taping, the full weight bearing. That's all fine. We then want to start mobilizing this joint. We'll practice this a bunch this afternoon. Exercises up to 3 times a day. Again, active range of motion, alphabet, toe curls. Has anybody done the put your foot down on a towel and try to gather up the towel? All that kind of thing. All that's good stuff. Intrinsic strength. When I say intrinsic strength of the foot, what do I mean? The muscles from here to here, okay? Inside of the foot. Yep, same thing in the hand. We did gripping stuff, we did extensions, we did abduction, adduction, all that good stuff. Same thing can go with the foot. You can put your foot in a rice bucket, whirlpool, whatever feels good and whatever gets it moving as far as I'm concerned. Gastroc soleus stretching, can't emphasize that enough. We can start that with some towel in a non-weight bearing position, and then we progress it to a weight bearing. We'll work on that this afternoon. Bicycle, great way to keep your cardiovascular, keep your wind up, not get fat, all this good stuff, because we've got to stay in shape. If we've got an athlete, right, we can't just say, hey, take 6 weeks off and do nothing. All right, so that's important. Strength and stability. We're going to start at partial weight bearing, go to full weight bearing. We'll take you through the entire progression this afternoon. But ankle sprains take a lot of rehab, okay? Then we get to this return to function phase. This will begin when exercise is pain-free, no edema, no antalgia. I'm telling you what, you may still have edema after these sessions, okay? It's just got to be controlled. We got to maintain protection during activity. All right, so people who've had these ankle sprains, did you wear your brace at therapy? It depends. You say no?
I think I wore it too and had to take it off or something.
That's usually what I had them do. I have them bring it with them, and I would make them do pretty much everything without it, unless we started doing sport-specific types of stuff. Because if they were going to compete in the brace, I wanted to make sure they knew how to compete in the brace, okay? That's important.
I feel like they do that.
What you got?
Like, I feel like they make you just get it and like not really maintain the strength in your ankles.
Totally agree.
Because like if I wear those that you tie up, and so let's just say if I like forgot my ankle braces.
Yep.
Like I feel like I had no stability, no
Correct.
control.
Completely agree.
So like I feel like after a while the athletes should wear braces.
I totally agree.
Like in volleyball, they have a really big tournament called Big South in Atlanta, and it's at the Georgia World Congress Center. It's like a huge tournament.
Been there. That's crazy.
But they like advertise like there's people out there selling ankle braces.
Of course.
People, like wanting to do it, so it's kind of hard because like
It's all about marketing.
yeah.
Yep.
So I feel like athletes they should have it at first, but then it should be a point where you start to like wean yourself off.
And a lot of times that's our role, is to get them to wean off of it. It's hard to get them to do it though,
Yeah.
because like you said, you feel naked without it.
Yeah.
Yeah.
I mean, like roll my ankle in a practice that I didn't
Yep.
have to. So
Yeah. But again, I will highly encourage them when they're in therapy, under my eye, there's no bracing. Okay. Now, that doesn't mean I won't teach them how to put it on, how to take it off, when to wear it, when not to wear it, how to clean it. We got to go over all that stuff. Okay. Adding resistance. How do we add resistance to some of these exercises? What resistance can we add? We can't tie a 5-pound weight to our ankle, can we? And do this all day.
Weight bearing?
TheraBand is a good way. What else?
You can just weight bear?
We'll find out this afternoon. We'll find out this afternoon. Proprioception and stability. Okay, proprioception, very difficult to measure, right? But we know that people lose proprioceptive input when they injure an ankle, especially when they have swelling. All right? They're more likely, in other words, they're more likely to sprain an ankle that's already been sprained, or sprung, as people like to say. Don't let them say that. It's sprained, not sprung. I sprung my ankle. But if you sprain it once and you don't rehabilitate properly, especially this proprioceptive stuff, you're gonna have, it's gonna happen again. It's gonna happen again. Plyometric jumping to sport-specific activity, the stuff the guys doing on a BOSU, really advanced types of things. Obviously, that's gonna be somebody that's getting back to high-level activity, but we gotta train them. We gotta get them back to that. So don't just leave this alone. You know, and a lot of times what happens, I've told you this before, people's co-pays go up, they get restricted visits, whatever the case may be, you may never even see them in this phase, but it doesn't mean you don't address it. You work with their athletic trainer, you work with their coaches, you work with their parents, you work with them to get them through this phase, if you don't get to do it. Because you'll be surprised. A lot of people are going to self-discharge themselves before they get to this point.
So like with this whole thing, there's no time on their phases.
Nope. Because it's all going to depend on the severity. If you got one of those that's black, blue, green, swollen like that, it's going to take probably 3 to 4 months for this whole process to go. Maybe even 6.
So when you have an ankle that's surgically repaired, is it faster since it's been surgically added, I guess?
It's a good point. I think for the most part it is. But more times than not, they're not going to do surgery on an ankle that's big, hot, red, and swollen like that. They're going to let it come down and then they'll do the surgery. So already the healing process has already taken place for the most part. But yeah, I think they do better. Yep.
So the first time I sprained my ankle, I feel like I was only in therapy for about a month, and like everything went down, it was better.
Yep.
The second time, same exact thing, landed on the other girl's foot,
Yep.
turned it, I think, and it was black and blue, it took about 2 or 3 months.
Yep.
To fully heal.
Yep.
And it was still like really super weak, because I was
Exactly.
out for so long.
Exactly, because you can't do much with it. It's tough, and it's very recurring, unfortunately. See it over and over and over. It is better to fracture an ankle than to severely sprain it. I would much rather. The only problem is most of the times they're concurrent. But if we've got a bimalleolar fracture like this, like they've just shattered this fibula here, and then they've got a fracture to the malleolus here. This is the surgical fixation down here. We've got a plate with 6 screws in the fibula, and we got a huge screw in the medial malleolus. Now, what do you think? Tell me what you think this ankle looks like. Hugely swollen, disfigured, awful. Maybe penetrating the skin if this comes out more. Okay, this is gonna be ugly. What's this one gonna look like? Let's say they do this in a, I think this was a guy that fell off a roof. And he just landed right on his calcaneus and just shattered everything here. All right, so he goes obviously to the ER. He has surgery. By the way, if this ever happens to you or your family member, when you go to the ER, do not let the on-call physician do this surgery. Wait for the specialist. You want a foot and ankle specialist doing this surgery, not a general orthopedist. Okay? So take your pain meds, chill out, whatever you gotta do, but wait this out. If the foot and ankle guy is not working that weekend, put it in a splint, do whatever, and let him do it on Monday. Okay? I think I told you about my mother-in-law when she fell out of Jordan Hare and her wrist is going this way. We put that sucker in a splint. We got her back to North Carolina. I call the hand surgeon and I say, I got a live one for you. He's like, I'm glad you did. We don't need a regular orthopedist doing that surgery. Okay? That's just a sidebar there. But what do you think this is going to look like when it comes to therapy?
Stiff.
Stiff is the understatement of the decade. This thing is not going to be moving, okay? You're gonna have a huge incision, both on the outside and the inside, and it's not gonna move. It's gonna be swollen. It's gonna be in a brace, and they're gonna say, okay, let's do some rehab. That's fun right there, let me tell you. It's not gonna hurt a whole lot, because it's not gonna move. But once you get it moving, things are gonna happen. What can happen here? Can you dislodge hardware?
Yeah,
Absolutely, absolutely.
depending on where those ligaments are lined up on there. too.
Exactly.
Cause
All right, so-
issues.
Is that like in the bone on the medium side?
Yeah, absolutely. But look at this. This is not in the bone. So where is it? It's right underneath the skin.
Yeah.
I have had this happen several times. I'll be doing some mobilization or something, and all of a sudden a trickle of blood comes out. Hardware appearing. Okay? That's not real pleasant. Doesn't feel good, doesn't look good. No, because it happens. And it's gonna happen. So what do they do when that's the case? Well, I call the doctor and I say, you know, this screw needs to come out. And that's what happens. They'll take it out. If it's healed,
Yeah, do
look
you
at that.
have
It's
some-
look at how well that's healed now.
I'm sure you can't wait, but do you have to wait? Like, how does it work?
What, if
Because
it's
like, okay,
spewing
it
blood
comes
and all
out-
this?
If it comes out and it's not like in a good.
It's not like it's gonna
spot.
come out. It's just gonna poke through the skin.
It's like a pinprick.
Yeah, it's like a
gonna just
pinprick. And then it's just gonna be,
trickle out.
So they take it out.
get the blood down,
Run that thing right on
and
there.
you send them to the doctor. And the doctor's expecting, it's not a shock to them at all.
Is that an Allen head or a Phillips?
Allen wrench.
Pull it right out with the wall.
If it happens too early, that's problematic. That's problematic. If it's not healed, they shouldn't be at your place. Okay? But it's happened. More times than not, the doctor's not gonna let them do anything outside of this brace. They put them in a cast for 4 to 6 weeks, a walking boot for a couple weeks after that, then they'll go to therapy. And you can imagine how stiff that thing has gotten. Yeah, you gotta move it, but don't be scared, because it needs to move. Now, are they gonna have the inversion, eversion that everybody else has? Absolutely not. Absolutely not. They will hopefully have dorsiflexion, plantar flexion, but it's not going to move laterally very much.
It's too late for you. I did when he was 16.
My financial planner guy, he fell off a roof and completely, his calcaneus, right, so this bone, 13 pieces. 13 pieces. So the doc at Duke took a wire and threaded it through the 13. It was like a necklace, if you will. And then he cinches it up and puts it on here, puts him in the brace for 6 weeks, and then he comes to me. Oh my gosh. That was a brutal rehab, yeah.
So like, I know they won't be able to do inversion, eversion, but is that motion contraindicated while they're in the cast?
Yes, when they're in the cast, you're gonna tell them, they're not gonna be able to do it.
Yeah.
So it's not a big deal. But you're gonna try to get as much as you can get out of it. But I can't tell you how much it's gonna be. It's all gonna depend on how many screws and plates and all that kind of stuff it is. But they can take those out. They can take those out. Once the bone is healed, they can take those things out. Because again, there's not a lot of tissue down here. Okay?
So this is just like a temporary hold until they get.
It will, I don't wanna say it's temporary, cause sometimes
They'll just stay.
it'll just stay in there. But if you got somebody with really thin ankles and so forth, you can see the plate and all that kind of thing. More times than not, they'll take it out.
We had a guy come in the clinic who fell through a dock,
Yeah.
broke his foot, like his toes were touching his shin, just
Yeah.
completely shattered. And he's got a plate in it, and it's just there.
It is there, yeah.
And he said it feels his right foot, I guess it was, compared to his left foot. There's no like visible difference. Even like measuring, it's almost completely non-existent. He said it feels huge because that plate's in there and the proprioception is
Yeah,
off.
so all that's off, and it's something you got to retrain. So the worst foot and ankle I ever had was, I'll never forget this dude, 26 years old, on his motorcycle, going around a corner,
Laid it down.
20 miles an hour, and sticks his foot out. That's not gonna work. And it took his foot and flipped it all the way around. So I will never forget looking at the x-ray. This talocrural joint was in 26 pieces. It looked like cornflakes on the x-ray. So they go in, and he had more hardware than that picture had, because he had these little screws into these tarsal bones. Gruesome. The first time I looked at his foot, you guys are too young to know about like Fred Flintstone and all this stuff. His foot looked like Fred Flintstone's foot. It was, his right foot was literally twice the size of his left foot the first time I saw it. And this guy was just not real bright. Oh, he wasn't real smart. He says to me on the first visit, "How long is this gonna take?" And I'm like, "What are you talking about?" And he's like, "Well, when's it gonna be back to normal?" I said, "Never in a million years is this gonna be normal. Have you looked at your x-ray?" "Oh, it'll heal up, I'm young." No. That's never gonna be the same. He blamed it on his girlfriend who was riding behind him. She leaned too far and he stuck his foot. He was something for him. He ended up coming to therapy for about 6 weeks and he quit. He said, "It's not getting any better, I quit." And it probably wasn't going to get a whole lot better, to be honest with you. So, after fracture, you're going to have a lot of weight bearing restrictions at times. You're going to have protocols that you need to follow, all those kinds of things. Don't mess up some surgeon's work. Respect what he's done. But for the most part, you're not going to see him until it's healed. So strengthening again, we start with isometrics, going to TheraBand, more dynamic stuff after that. Proprioception. We'll talk about all this stuff. Monitor for hardware loosening. Okay. It can happen on their own, and you need to prepare them for that. Had a lady one time, she was doing a dorsiflexion stretch with a towel, and her pin popped out. Okay? Not a big deal. The pins are really, really easy. They will just take the pin and pull it out, as long as everything is healed. They'll take an x-ray first just to make sure, but the pin is really simple. A lot of times they'll use pins on hands as well. Literally all they do when they remove them is they take it, pair of pliers, and they go, and then the blood comes. It's just fun. But if you've got somebody and you're doing mobilizations, your passive range, whatever it is, and you're stretching, they're stretching, and they start to have not only increased pain, but clicking, it'll feel like something's loose, something's probably loose. Okay? That's when you let your PT know, and your PT will call the doctor and set up a time for them to go see him. Because it's gonna happen. Don't freak out if it does. All right. Total ankles. I I've personally seen about 10 of these, not real common. Advanced temporal damage, but the only alternative is arthrodesis, so they've got to either fuse the ankle or put a replacement in there. The ideal candidate for somebody like this is somebody who is older, thin, and not very active. Because if you are larger, younger, and active, this is not going to work. All right? There's too much weight bearing, too much loading, too much torque, all this stuff. But if you've got somebody who's not real active and just wants to be hopefully rid of their pain, this is something that might work. Yes, ma'am?
So this is like last resort for them. They'll try to do repairs or anything before
Yes.
they do this. Okay.
Now, as it says in here somewhere, or maybe it's the next slide, you're starting to see more as the technology gets better, as the materials get better, younger people having this surgery. But again, you gotta think about what's going on here. We got a fully weight-bearing joint, and we're putting a lot of tension through there, a lot of stress, weight-bearing, and torque, and all kinds of different things going on there. So it's not simple by any means. But again, if they're good candidates and they follow what they're supposed to do, this really is a pretty good alternative. And again, they're gonna be immobilized for about 6 weeks. You just try to get back everything that you can get back once you start to see them, and just try to get them as strong as they can. But you'll be under very definitive precautions and limitations. Just follow those. That same guy at Duke did a bunch of these. It's pretty much all he did was ankle surgery. That's who you want doing your surgery. Achilles tendon ruptures. Anybody's dad or anybody had this? Anybody seen one of these? Yeah. This is pretty gruesome. Yeah, it's a. I was playing baseball with a guy who got his severed. He was covering first base, pitcher going to cover first base, and the guy stepped on the back of his ankle and spiked it so hard that it severed it. Now, it was a clean cut, so that was pretty easy for them to repair. But for the most part, repair is going to take place. There's very, very few, like down here where it says non-operative, immobilized for 8 weeks or more. They'll put them in a cast, okay? And it will be in relative plantar flexion to try to approximate the tendon. If it's fully torn, it's not going to heal. But if it's a partial tear, they may try this. Okay? But you'll probably, when you see these, you'll see more of the operative. It's usually the distal third of the tendon. It's usually a sudden eccentric, concentric contraction. Somebody jumps, cuts, runs, and it's usually guys between 20 and 50. I mean, like clockwork. Basketball, racket sports, things like that. It usually is going to occur on the distal third of the tendon due to the lack of vascularity. What's our test that we do for this one? Not all at once, people. Not the Thomas, the Thompson test. Yes. You're just gonna squeeze the gastroc, and if it goes into plantar flexion, you're good. So an interesting fact, and I don't have it on here. Interesting fact. So I had a guy who was getting ready for the NBA and tore his Achilles. He was probably 23 at the time. Very thin. This guy was 6'6", about 200 pounds. Real thin. So when they repair the tendon, everybody's seen somebody with real skinny ankles, right? Their Achilles looks like it's about that wide, right? So the first time I'm dealing with one of these, this is probably maybe my 3rd year out of school, and I see this. He's got super, super thin ankles, and I look at the other, on the repair side, and now his Achilles is twice as wide as the original one. Why is that? I didn't know. It's just tends to broaden when they bring it together, it grows outward too. Okay, so is that gonna make it different? Absolutely. You're gonna have more scar tissue. That's one surgery that you're gonna do a lot of scar tissue manipulation, because that incision that they'll make is longitudinal this way. Because there's not a lot of fat or any other tissue around that scar tends to bind down to that tendon that's surgically repaired. You've got to get in there and break that up. And that's not real pleasant, people. That doesn't feel very good. But I remember working on that, and that tendon just kept getting broader and broader, and ended up twice as big as his other Achilles. And I finally went and looked it up, and yep, sure enough, that's pretty normal. But this is a very difficult and long rehab. How long was KD out? Full year, right?
Yeah, I was.
Kobe was full year. And both of them came back pretty well.
Yeah.
But again,
I'm not a KD for
he still doesn't have quite his spring that he used to, right?
Tricky.
So again, if they try it, even with surgery, they will put them in a cast or a walking boot. It may even be non-weight bearing for a while. These are the people that ride around on a little scooter thing, a little knee scooter. Once out of the cast, 6 to 8 weeks after surgery, they will transition to the boot with a heel lift. What is that going to do? It shortens the gastric, doesn't put the strain on it, okay? And what you're going to do gradually is you take this, you see how this has got differing levels? You'll take one out every 2 weeks, 3 weeks, whatever the doctor wants you to do there, until it gets flatter and flatter, and that gastroc can stretch out. But it's slow. It's a slow process, okay? Modalities is indicated. Again, a lot of soft tissue work. I've seen people use ultrasound on this kind of thing. You can start strengthening. Again, same kind of procedure. I would start with isometrics, TheraBand, closed chain, all that type of stuff we'll talk. Toe raises only if no complications in the late stage. You can imagine how stressful it is to come up on your toes on a healing Achilles repair. I will never forget the first time that same guy I was talking about, I had him do that exercise. His eyes got this big. He's like, oh, that didn't feel right. I was like, all right, we got to keep working at it. And he ended up doing fine. He was with the Rockets for a little while, but didn't make it for the full go.
So is there like training you can use to prevent these?
To prevent?
Yeah, because like, okay, you know how you can do ACL training.
Absolutely.
So, like strengthening.
Well, what would you do?
I don't know, that's why I'm asking you.
Well, think about it. We want to strengthen the tendon.
Well, since this is like a jumping injury, would you incorporate it into like ACL training too?
Yes. But these are pretty freakish injuries for the
That's
most
what I
part.
was thinking. It's not something.
It's not something you can really avoid. It's just what it is. But yeah, I mean, all the running and jumping that they're doing, especially playing basketball, volleyball, things like that, tennis, all that's going to get them ready for them. Yep.
Anybody ever studied like the Maasai tribe that can jump so high? Have you seen those guys? They have like crazy plyometrics. They're a tribe called the Maasai, and they're like I don't remember what part of Africa, but they just stand there static and they can jump like 4 feet in the air or something. That's crazy.
I'm just assuming that they have a higher percentage of fast twitch and all that good stuff. Yes, ma'am.
So I was just thinking about like in the past we were talking about how tendons and ligaments aren't like contractile tissue. It's like when you're saying that you're doing like ACL training or like Achilles training, like I don't understand how that like correlates. I mean, I know you're strengthening the muscle around it.
So you
but
have to
not
think
actually...
of it as a continuum. We go from contractile tissue to a musculotendinous junction. Okay? At that musculotendinous junction, there is contractile tissue and there's connective tissue, kind of blended, right? If you think about it. We can make tendons and ligaments stronger. can, and we need to. But I hear what you're saying. Physiologically, if you cut a tendon and you look under a microscope, it looks different than muscle tissue does. But we can train those tissues. Just not, it doesn't hypertrophy like a muscle does. But we can build strength within it, structurally.
Are you saying the strengthening is happening at that junction?
Yes.
For the tendon?
Yes.
More so than the actual, like.
Yes.
You're increasing like the elasticity.
Yes. You hope to increase the elasticity without injuring it. And that's
too much.
how much is too much? It's hard to say, right? Stress fractures. Any runners in here? Any runners suffered a stress fracture before? Probably kept running anyway, even if you did. This is due to repetitive loading with no time for the bone to repair. Usually it's going to occur at the distal tibia. Right. Right here. Distal fibula. Metatarsals, navicular is a place for stress fractures. These, how do they diagnose these?
Vibration.
Vibration is the first way they will do it, okay? They'll take the little tuning fork and hold it on an area, and if it vibrates and it hurts, pretty good indication. But what's the gold standard? How do you diagnose these? Nope, x-ray's not gonna show it. These are micro fractures. Bone scans. So bone scans will come back and the area will look red hot on the bone scan. Okay. Common causes. Training errors. Overtraining. Too much, too soon. On bad surfaces, with bad shoes, bad mechanics. Poor nutrition. All those things can contribute to this, okay? So these are all things that we can control, right? We can control every single one of these. Absolutely, because it's repetitive, yeah. Yep, and they do it over and over and over and over. And they don't get rest.
Okay, that's my question.
Yep.
Like, how is like PTAs, do we like, I guess like encourage people to like take the time off? Because like, okay, for example, I coach. I can't like take off my job because my shoulder is hurting, but I shouldn't be coaching because my shoulder is hurting. So that's like an argument where you have like, how do you encourage patients to take the time off, but understanding like
That they're not gonna do
that
it.
they're not gonna do it and they have to do it?
You just have to understand that. Then I teach them compensatory measures, because I know they're not going to stop doing it. So I'm gonna teach them a lot of cryotherapy, pain relief, recovery. You know, I know that runners run. Right? Athletes compete. It's gonna be hard to keep people off of whatever. But the most important thing is communication and honesty. What I don't want is some runner to come see me for their stress fracture, and we do all this stuff, and then I ask them, "Are you running?" And they say, "No, I'm not running," but they're running. Then I'm not getting all the facts then. I need communication, I need honesty. But, you know, a lot of times that we can do things with, you know, you've got somebody who's got a stress fracture, I could put them in the pool. I could put them on a alter, you know what an alter G is? It's a treadmill that minimizes weight bearing. They step into this like, it looks like a trash bag, but they pump it with air so there's less stress on the joint, and you can take it up to where it's almost zero weight bearing, but they're still running. Very expensive machine, but a lot of places have them. You can put them on a treadmill. There's shock absorption built into a treadmill. People who run on treadmills for the most part don't get stress fractures. It's because they run on asphalt. So again, lots of different things that we can control. You just have to be honest with them. And you need honesty from them. Dancers are the hardest though. I mean,
It's bad. It's really bad.
they don't stop. They don't rest. No time for ice. This is their best friend here, this rocker boot. They spend more time in that than they do anything. And then they get out of it and go right back to dancing.
Well, then see, and most of them they don't even wear it because they don't want their dance
They don't want to appear that they're hurt, right?
Yeah.
Yep,
So it just keeps getting worse and worse.
correct, correct.
So you'll just see them like their ankles just wrapped all the time.
Shin splints. Anybody had shin splints before? Really painful, really painful. So there's a lot of different things that can occur with this. If you break them down, you look at the research with shin splints. Medial tibial stress syndrome. So if you have it on the inside or you have it on the outside. This is the medial, pain in the distal 1/3 medial tibial border. Origin of posterior tib and medial soleus. Usually, again, same kind of stuff we were talking about, mechanics, conditioning, footwear, all that stuff. They may be an overpronator. They may have problems with their hip and ankle range of motion. That's something we can address. If you look at somebody with tight hips and they have this, let's stretch their hips, okay? Tight gastroc soleus, they're gonna know about that from the beginning, but encourage. A lot of people don't know how to stretch soleus, and we'll talk about that this afternoon. They know how to stretch gastroc, but they don't stretch soleus. Anterolateral, that's going to be more for the anterior tib, and that'll be on the outside, and this is a little more proximal usually. This is usually an overuse injury of tibialis anterior and micro tears. Super painful though. Usually that they're not in proper shape, it's weak, they got tightness, all these types of things. These are very, very similar things. What's the best thing for this? Rest. But then when you get to the rest, you get the deconditioning. So that's why I say bicycle and things like that, alternative, getting them in the pool, keeping them in shape, but not putting more stress to these tissues. Ooh, compartment syndrome, one of my favorite things to talk about. I think I probably told you about this kid that I saw. So compartment syndrome, increased pressure within the myofascial component. So if you look at, you take somebody's leg and you got a gastroc, big gastroc, soleus underneath that, put them into dorsiflexion, you can see this anterior tib, you can see the perineals, you can see the, you can't really see posterior tib because it's behind it, but each muscle belly is encased in fascia, okay? If you do a cross section, if you chop somebody's leg in half, you would see all these different compartments. So, my patient, senior football player in high school, running back, he gets going around the end on a sweep, and he gets hit with a guy's helmet right here. Okay, right at the muscle belly of the anterior tib. All right, so pretty vascular structure. It starts bleeding on the inside and swelling greatly. This has now become a medical emergency. This is now compartment syndrome. And the ways you look at that are the 5, or actually I think there's 6 P's. You look on the fine print down here. Pain, paresthesia, pressure, pallor, so the color, paralysis, and pulselessness, okay? If this bleeding that's occurring internally is so great, and the tissue damage, the swelling that has occurred, you're gonna start to cut off the neurovascular structures. This is a problem, major problem, like go to the ER problem, okay? So athletic trainers are very well versed in dealing with this kind of thing and assessing this. Now, this can be acute, like my kid was with the helmet, or it can be an exercise-induced thing. You've got runners and athletes that for some reason swell more than others when they run. This can be a real thing, okay? Normally it's going to be trauma or a severe contusion, however, okay? Also, if you give somebody that gets put into a cast or wrapped too tightly, this could be a problem as well. So the acute treatment of this is called a fasciotomy, and this is what you see right over here. And this is what had to happen to the kid I was working with. They take you and they cut you wide open, and usually it goes all the way to the ankle. And they just let this thing drain. And this may have to be this way for a week or so. So for my guy, they cut him from here to here, let that open. Now, risk of infection? Absolutely, it's huge. It's huge. He didn't get infected, but he lost his perineal, so he really struggled to evert and to dorsiflex. So his main thing was, I'm a senior. I want to run out of the tunnel one last time. We would not clear him to play, but he did get to run out and be dressed and everything for his final game. We also put him in an AFO. Have you guys talked about AFOs in neuro yet? Okay, so we put him in an AFO that kept him in a dorsiflexion, so he could at least get out and be able to walk out onto the field and so forth. But yeah, that happened. I think it was the first or second game of the year, so it was probably we had about 8 to 10 weeks to get this right. It was pushing, because that was a huge incision that he had there. But it was a really inspiring. I remember going to the game and everybody's crying and all this stuff, because he almost lost his leg. This could be amputation. But if you've got a chronic situation here, again, rest is going to be huge. Again, getting runners to rest doesn't work very well. So you've got to teach them how to control the inflammation, whether that's through oral, cryotherapy, whatever the case may be. But again, it can be very, very, very dangerous. Plantar fasciitis. Anybody had this? This is not fun. First time your feet hit the floor in the morning, feels like a nail is getting driven right through your heel. This is what this is supposed to be indicative of. Pain from inflammation, not the spur. The spur is not what causes the pain. The spur causes the inflammation, what causes the pain. Again, the hallmark is the first step out of bed, especially if you're someone who sleeps with your foot in relative plantar flexion. Because as soon as you come back into dorsiflexion, this thing gets stretched and, oh gosh, that's the worst. It's the worst feeling. With microtrauma at the origin of the calcaneus, it's very common, very, very common, and the pain will shoot all along. Causes: flat feet or pes cavus. Either one can cause this. Okay? One's usually due to a tight gastroc, one's due to weak proximal muscles. Obesity. Just the increase of weight bearing tends to make the bone spurs more problematic. Some people just grow bone faster than others too, so just things to think about here. Treatment, obviously activity modification, ice, stretching, can't stretch enough, strengthening as needed, taping, there's all kinds of taping techniques out there. I had good success with iontophoresis. Cross friction massage, you roll in a golf ball or a frozen water bottle on the bottom of the foot, it feels really good. Then there's these night splints. This is called a Strasbourg sock here. It just holds the foot into a little bit of dorsiflexion. This is a more dynamic splint here. They work really well. But can you sleep with those things on? Not always very easy to do so. But again, this is usually due to runners overtraining. But it can be people who are not runners as well, if they have a predisposed problem with the foot. Anybody seen anybody yet with plantar fasciitis, treated them? What'd y'all do?
Ultrasound.
Ultrasound? Stretch, a lot of stretching, digging in. A lot of times I'll get the,
Taped it too.
did you? I'll get, some of the tools, and it'll be one of the guest speakers that comes in and talks about, actually Ms. Ann does a little bit of that too. Instrument assisted soft tissue stuff with, hawk grips, all this kind of stuff. Really works well. There's some more invasive procedures, things like what they call prolotherapy, where they inject saline into joints and try to stimulate a inflammatory response so it builds up resistance against it. It's all kinds of theory out there. 10X is another procedure that I've seen with this. They'll do, almost like we talked about when we did microfracture stuff. This is what they'll do to the tendon. They'll put little holes in the tendon to try to make it grow back. You know, I've seen some good cases, I've seen some bad cases with those things. If you see something like that and you don't know what it is, just make sure you're communicating with your PT and the physician. Morton's neuroma. Anybody seen this before? You guys talk about this and, yeah. This is usually due to closed-toed shoes, too tight. It's usually between third and fourth digits here. I've seen it between second and third. You've got some nerves that come in through here as well. But this just gets red hot, electric type pain. First thing that they'll do is tell them not to wear those shoes, of course. You try some stretching, things like that. But the majority of this is going to be injection, corticosteroid into that area to try to calm down the inflammation, and just trying to keep things mobile through here. Rest as much as possible. You can try to strengthen the intrinsic in the foot, do a little bit perhaps. More times than not though, if the injection fails, they just go in and cut these out. They'll make an incision right between the third and fourth toe. They'll take the nerve endings out, sew it back up, tell them to rest it for a few weeks, and move on with what they're doing. Did you have a question?
That was about that.
About that? Yep. Alex Valgas, bunions. You got a couple of those in here, I remember. Yeah. This is super painful, folks. Super painful. Hurts like hell.
If she just like walks around.
Yep. You bump that on the edge of the coffee table or something, that's gonna be problematic. Yeah.
You need to compare bilateral.
So conservative treatment, again, they go to a wider toe box. They can put some pads in here, change whatever activity is bothering them, things like that. But for the most part, this doesn't get better. It only gets worse. So until, you know, obviously you can see the deformity here. What they'll do is they'll take it, they break it, they shave it off, and they reconstruct it. So look how pretty that one looks there. The biggest thing about this one, after the bunionectomy, I've seen a lot of these. I had one podiatrist sending tons of post-op bunionectomies. Biggest thing to think about at this is obviously getting the swelling down, all that kind of stuff, is the great toe extension. You've got to make sure that the big toe can extend, because you've got to have that to walk, right? Once we get out and get to push off, that great toe has got to extend about 10 to 15 degrees for you to be able to push off. If you don't have that, you're going to walk with this real stiff gait like this, because you can't achieve that extension. So that's the one thing you want to make sure that you work on. I remember having this one lady, oh, she was awesome. Big Auburn fan. This was up in North Carolina. And she had the stiffest big toe I have ever worked with. I mean, it was like trying to mobilize this. And we worked and worked and worked on that, and finally it kind of broke through. She had a great outcome, she's very appreciative, but I would sweat working on that thing. Some other deformities that you'll see, and again, I would just know what these look like and at what joints and everything. Mallet toe, hammer toe, claw toes, they all tend to be, again, closed toe box, pointed shoes, boots, things like that. Why do y'all, ladies, why do y'all do that to yourselves?
To be cute.
Because they're cute.
The way society is, and why do men like it?
I don't know.
That's
I don't know.
why we do it.
That's the question. The fit has to go though, like the shoes on the edge, the whole fit is just
Let's just forget it.
yeah, kind of the whole fit,
I saw a lady in the airport the other day. She had on the pointed heels, and I mean, a spike heel like that, going through the airport. And I'm like,
Oh, yeah.
She's wild for that. You have to get to a place where that's crazy. You gotta get to a place.
That's what I'm saying.
She probably get paid
Yeah,
a lot of
now
money.
they
No,
changed
you-
the run now. But me myself,
she wasn't going to a business meeting either. I mean, she was just trying to look.
Cause like you only put
'Cause it's a
it
photo op.
when you need to, and then as soon as you finish, you go.
Come on, the airport, you
Yeah.
gotta
Okay.
I have to.
She wasn't.
In front of the sign?
She's flying through the airport in spike heels.
All I do if I look in the pictures and after I'm just
It's a runway. This is a fashion show.
So surgical treatment for this is they just break them, they'll pin them, pins are out, yeah, they'll just straighten the sucker out. And then they put a pin, run parallel to it.
Is this the only time they fix them for service? Cause like, okay, my brother, shot himself in the foot with some BB guns, and it's a whole story, but he like shattered his toe. Like, they gave him an X-ray and literally his toe was like in pieces. And so they just kind of like taped it up and went on about their business. So, because at first we weren't gonna tell our mom because we knew they don't really do much. But he literally couldn't walk, so I've never seen him really do much about toes, really.
It's gotta be pretty deformed for them to do something, but you'd be surprised.
That's what I think
So I had a
they're gonna do
friend,
something, but.
I had a friend whose toe crossed over another one. I don't know how that happens.
Got some long toes.
But you can imagine, oh, it was a mess. It was the worst looking foot I'd ever seen in my life. Crossed over, so they had to re-break it. It basically was a bunion of like his second toe. The second toe went over and crossed over his third toe. Yeah.
We have a guy actually right now in my clinic where they fused his toes together, so they're literally like cross.
They're
like,
just web type of thing.
pretty much like
Yeah.
his incision's like right there, like it's
Does it not affect like balance or
Should
something?
affect a lot of
It
things.
can't like I remember the PT his Dave out. He was like, let's try some towel scrunches, and yeah, that didn't work out. So this poor man.
Yeah. You're not gonna see a ton of these.
That's what I was saying.
And honestly, I've seen a couple get referred to therapy, but not even, I mean, a lot of times when they do them, they just tell them, you've got a pin there for 6 weeks, you just gotta chill out.
Did they snatch that one out?
Yep. Yep.
No fun outpatient.
But they'll put those in those boots and post-op shoes and stuff.
Got a brutal coming.
Pretty much let them go.
There's only 30 something of them. And then you
Um,
fine. That's my
The
favorite
things
part.
that we need to be able to do, we've got to be able to visualize and take a look and inspect their feet. What do you look for? Deformity, calluses, blisters, wearing a certain of the shoe in a different pattern. All kinds of things out there. I bet y'all's shoes look completely different than a lot of people, flattened out and so forth. Obviously, we've got to be able to palpate. We've got to be able to assess range of motion. We've got to be able to teach them and know how to stretch, strengthen. Manual techniques we'll talk about this afternoon, and shoes and orthotics. There's a lot to that. If you get to where your niche is dealing with the foot and ankle, you're going to learn a lot about orthotics. You're not going to learn about them from me because I don't know much about them. There are some very nice off the shelf orthotics that work very well. You can also get custom orthotics that cost $300-400. Most of the time, insurance is only gonna pay for the off-the-shelf, if any, because the studies really don't show that the custom does much better than the orthotics, than the custom. The custom doesn't do much better than the off-the-shelf. So, basically what the studies are showing, especially for these pronators, it doesn't matter what you put in the shoe, just put something in the shoe that gives them that rigidity that they need. Is that it? That's all I know. Any questions? So this afternoon, yeah, we'll go ahead. Let's be back at 12:45, and we will start lab. Actually, stop. Let's do this other quick little, teeny little lecture on performance stuff, and then we'll go to lunch, we'll come back at 1, and then we'll do lab. Does that work? Works for you. Any other questions, foot and ankle, real quick?
Is that quiz just on foot and ankle?
Foot and ankle, and then this little bit that I'm gonna do right now. And I think it's just 10 questions. So we're back to our normal quiz.
Sure. What do you want to do?
Yeah, here we go.
Right after lunch. That's cool. Hey, quick. Right after lunch, we're gonna have a closed meeting.
This will not take 10-15 minutes here. We'll fly through this. Because we'll practice more of this in lab. So, for advanced functional training, dealing with somebody who's trying to get back to sport and so forth, you know, we've talked about how they've got to be stable, whether it's core, joint, whatever, postural. We'll start advanced stabilization in easy. Put them in sitting, have them work on reaching. Maybe they're on the ball, on a Dynadisc, whatever that case may be. And then you're going to start making things harder. External perturbations, you know, have them push them, make them correct. But again, you're still in sitting, so they should be fine. From sitting, we go to kneeling. You kneel on a stable surface, like the floor, versus an unstable surface, like the Bosu, or Dynadisc, or even a foam pad, something along those lines. Something that gives them a little bit of unpredictability. The progression then is to bilateral stance, same kind of thing, then the unilateral stance, and then we go to more of a sport-specific activity. If we've got, say, a tennis player, we may have them do jump and freeze, side shuffles, run and freeze, things where they've got to learn how to slow their body down and accelerate quickly. Okay? Make it like their sport. Take them outside. If they compete outside, take them outside. Okay? Nothing wrong with going to their setting either. Upper extremities. Have a body play going. What kind of activity is a body plate?
Going.
Concentric, eccentric, isometric.
I mean, what's the measurement for what activity?
Both.
I've seen
Both.
teachers use that one.
It's a concentric to get it started, eccentric to slow it down, concentric to get it started again. And it's constant back and forth. That's why these are such great tools, okay? And you can do a lot of different things with this. Matter of fact, there's a study at Duke, I don't think it's published yet, but a friend of a friend is doing a study at Duke trying to measure how much better these things are than like TheraBand and stuff like that. So there's a lot of different eccentric stuff out there, especially for shoulders. If you work with shoulders, you need to become very in tune with those.
So like, if you were gonna train somebody, would you have them do that first instead of like with their TheraBand, we try to go through the full range of motion.
I will usually have them go through full range with the TheraBand first,
Okay.
and then once they can do that, then I jump to this pretty quickly.
That wears them out.
Yes, yes. If anybody has not done this, make sure you do.
We have a pitcher that comes in and uses that.
Oh, yeah.
And he'll just like bring it down.
It's phenomenal. Yeah, you can do PNF patterns. You can, I'll have them do like a series of 6 or 7 different exercises, and they're worn out. Everybody's worn out with that. Weight bearing exercises. We showed you some of these push-ups on different planes, walking on your hands, things like that. Pushing, pulling, lifting, lowering, all that kind of stuff. Seated push-ups on unstable surfaces, okay? How do we make it harder? How do we make it easier? Just like we talked about that one day. You've got to be able to progress these things. And you've got to be able to watch the patient and say, okay, I see poor technique here. I see core weakness here. How do you make those things better? Okay? That's what we're talking about here. Upper extremity step-ups, combined with push-ups, there's all kinds of stuff. Ball walk-out. Again, I'll have people do push-ups on these balls. We talk about hard, that's really hard. Lower extremities, we've already been through most of this with core strength. Supine pelvic bridges on elevated surface, supine hamstring curls on ball, that's really hard.
It's really hard.
Really hard. Wall slides, we've talked about that. Start doing all kinds of different things with all of these, just variations of lunges. I'll have folks do body blade in a lunge position. I'll have them with the cross cables do a lunge and then have to rotate while they're standing on the Bose. So you're just combining different things to really challenge. Band walking, I think I showed you guys that. Pushing or pulling heavy objects. In our clinic, we had tractor tire. I mean, you talk about just teaching them how to deadlift that and explode through that lift. Phenomenal. I mean, it works every muscle in your body. Resisted running start and resisted running. You put them on like a strap system. Have them, you can be on a scooter or something, or a stool, and have them pull you, or you can put a parachute behind them that will slow them, or just give them resistance. Hopefully it slows them a little bit. But again, plyometric training is essential to these high-level athletes, and you have to train that way. Very high velocity, eccentric to concentric loading. They've got to be able to change direction and rotate very, very quickly. Has anybody heard the term amortization phase before? So, if we know what plyometrics, come here, athlete. Stand up on the, here. Oh, God, stupid slide. Take those off. All right, so, if I tell him I want him to jump from here to the floor and then jump as high as he can. Go ahead and do that for me. All right, so he's going, come back up here. So when he hits the ground, he is stretching certain things and shortening other things. And then we're reversing it very, very quickly. But that reversal, the pause down here, is called the amortization phase. We want that to be as short as possible when we're training at the highest level. All right, so come down and explode as quickly as you can. There you go, good. As soon as he hit there, he's back up. That's good, perfect. Stores release of the elastic energy. So when he hits the ground, there's an elastic stretch to his gastroc-soleus, probably even his quads, and we explode off of that. That's what we're trying to maximize with those types of things. Reactive neuromuscular training. A lot of times what I'll have people do is do body blade and stuff, and I will have flashcards or something like that where they have to turn and look their head and tell me number or a light, or they have to hit something. There's a new thing out, Kevin Wilkes got it. Anybody watch Kevin Wilk? He's big on this now, and it's one of the great things. I learned a lot about it at the conference in January this year for baseball. He's got them in a push-up position, and he'll put a series of lights in front of them, and they have to go in a certain pattern while they're weight bearing on this opposite side the whole time. So again, just making the connection between what's going on with the mind and what's going on with the body. Because obviously, those are things that can be trained. Contraindications for plyometrics. This is a board question waiting to happen. Pain, inflammation, or joint instability. You cannot have people do that when they have shin splints. Okay? You cannot have somebody do that when they've got patellar instability. Right? Just make sure that when someone is doing plyometrics, these very, very high level activities, that they are sound. They have got to be sound. And again, a lot of times they're going to leave you before you get to do these with them. But I always try to have that conversation. You don't do running, jumping, cutting, all this kind of stuff until you are close to 100%, if not 100%. Because this is trying to get that 100% to the 110%. Again, preparation for plyometrics, you better have a very, very strong base. So core's got to be strong. Quads, glutes, got to be solid. You can't have people wavering there. If I see somebody and I'm having them do a jump drill and I see them diving into valgus, stop it. They could tear an ACL under your watch. That's not going to be good. Okay? Specificity of training. If people run and jump in their sport, we've got to run and jump at the end of their rehab. It has to be. Has to be. Progression. Again, always start with that warm-up. Give them proper rest. If their sport is one that involves explosive activities, give them plenty of rest. Demand a lot from them when you are concentrating, but give them ample rest. High potential for injury and re-injury with this. Okay, so if you got somebody who's coming off an ACL and you start doing this kind of thing, they're going to be a little apprehensive. It's okay. You've got to walk them through it, do it slowly at first, and then you amp things up as much as you can. These are just suggestions here. Again, these are diagonals, chest press and throw, overhead catch and throw, side throws. I mean, I love doing stuff with a medicine ball that bounces. You've seen us do that before. Hand-to-hand catch, unilateral plyometric using elastic resistance. So I will have somebody do speed stuff up at a 90-90 position here. Bounce weighted balls we talked about. So you got to think about that. You're doing concentric work to throw this ball, and as the ball comes up, you've got to slow it down. So you get the eccentric coming right back at you. Fantastic. Love that stuff. And be creative. You can use stuff against the wall. You can have somebody throw it at them. You know, whatever. There's no wrong way to do it. There's just wrong times to do it. Slide board, push-ups off the wall. Yeah, you can do a bunch of different things. Variations of push-ups. Lower extremities, start with kicking. Yeah, I saw a lot of soccer players. They all want to know, when do I get back to kicking? When do I get back to kicking? Well, think about what has to happen for that to occur. They've got to have a strong plant leg, good glute strength and quad strength here, but they also have to have the range of motion and so forth to not tweak a hamstring or what have you. So there's a lot that goes into all that. We've got to be able to assess that. Mini tramps, I love doing stuff with that. Shuffling, slide board, all kinds of good things. This is fun stuff. Squat jumps, tuck jumps, lunge jumps. And again, moving, cutting, hopping, single platform, multiple platform, endless amounts of things that you can do here. if this is something that you want to do, work with athletes, I would suggest going to a continuing education course where you see somebody who really knows what they're doing with this, because they can get really creative and really demanding. You're gonna learn a lot at something like that. Much more, unless you're at a clinic that you're seeing all that type of stuff. But more times than not, we're not in that setting. All right, back at 1. Ready for lab.